Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Behavioral Health Workforce Education Training Grant Webinar, and it was presented by Beth Phoenix and Jennifer Matone on July 10th, 2019. My name is David Armstrong, and today's webinar focuses on best practices for program evaluation. And joining me is Jessica Boki and Maria Gazer from the Behavioral Health Workforce Research Center. Now, after today's presentations, you may ask questions using the chat panel on your screen. Also, when the event ends, you will be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. Now, with that said, Jessica, would you like to go ahead and introduce today's speakers?
Yeah, Maria will actually. Thank you very much.
Okay. Sorry about that.
No problem. No problem. So we are pleased to introduce today's speakers, Dr. Beth Phoenix and Dr. Jennifer Matone. Dr. Phoenix is Vice Chair of the Department of Community Health Systems and Health Sciences, clinical professor at the UCSF School of Nursing. Dr. Matone is an assistant professor of school psychology and psychiatry and also associate director of psychosocial research in primary care in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at the Children's Hospital of Pennsylvania. So we have just a few housekeeping things to take care of before we get started. First, this webinar will run for approximately 30 minutes. We will be recording the session for those who are unable to attend today, and the recording will be made available on the Health Workforce Technical Assistance Center website, as well as the BHWRC website, and on the BHWRC social media accounts next week. And second, we'd love to hear from you today during today's presentations. So if you have a question for either of our speakers, feel free to send it through the chat functionality. And we'll be answering questions at the end of today's session. And if we're unable to get to your question during today's webinar, we will follow up with you via email. So we'll open today's session with Dr. Matone, who's going to share some of the strategies that she uses to evaluate her BWT training program successes and challenges and student training performances. So both of our speakers will help us answer some commonly asked questions and concerns about best practice strategies and evaluation tools using their BWT program experiences. So without further ado, we'd like to welcome our two presenters today, and we'll open with Dr. Matone.
Great. Thank you very much. I'm really excited to be here and to share some of our information about how we've gone about evaluating our training program in our integrated primary care service. I do want to just mention my two colleagues, Dr. Billy Schwartz and Dr. Tom Power, have both been other critical leaders in the development and implementation of this project, but they're both not able to be here with us today. So I'm going to be speaking for all of us. So we're going to talk a little bit about how the context of where our training program exists in terms of the whole hospital health system. And then I want to talk specifically about our project training goals, including for program and curriculum development broadly, and then how we implement and evaluate particular experiential training to determine how our trainees are meeting their competencies. And then we'll talk about our program evaluation plan and share some of our recommendations for best practices as you move forward with the evaluation of your own kind of similar training programs. And so this just illustrates sort of the multiple levels of behavioral health service delivery, the way that we conceptualize it. And our trainees rotate sort of at the base of that pyramid in our Healthy Minds, Healthy Kids program, which is the Integrated Behavioral Health and Primary Care Service at Children's Hospital of Philadelphia, or what we call CHOP. And as is the case with integrated care services nationally, our goal with Healthy Minds, Healthy Kids is to support patients and families early, hopefully to alter the trajectory of problem development, and to improve access to behavioral health service delivery. So we're serving as consultants to patients, families, and primary care providers. This is often a new way for many of our trainees to be working as behavioral health providers. So we do not actually expect that trainees come into our training program having had experience in primary care, although many of them do. So we have trainees in psychology, child and adolescent psychiatry, and clinical social work who rotate with Healthy Minds, Healthy Kids attending providers in all three disciplines. They work predominantly in primary care practices that serve a high proportion of patients who are Medicaid insured living in the city of Philadelphia. Although our Healthy Minds, Healthy Kids service spans the greater Philadelphia region more broadly, our trainees are focused on service delivery to urban underserved communities. All of the patients we see are patients of the primary care practice where we're embedded. And you can kind of see a little bit of an overview about how we provide our service. We strive for a fully integrated model where behavioral health providers and primary care providers work collaboratively to support our patients. And so to get more specifically at our BWIT training grants program goals and our evaluation plan, here you can see our project goals that were specifically focused on program development. So our psychology internship program here at CHOP is accredited by the American Psychological Association, and it has several subspecialty tracks, one of which focuses on integrated behavioral health in primary care. Before this training grant was funded, we had one department-funded intern on that track. We have had many years of funding from Graduate Psychology Education, or the GPE program, through HRSA as well, and with those grants, we've been able to have other trainees, but as that funding ended, again, we were able to get one department-funded intern. So we're really excited that this BWIT grant has allowed us to expand our capacity up to 4 trainees in the last year, and over the course of this project, we're prepared to expand up to as many as 5 or 6, and then hopefully continue to work on our sustainability plan to increase the number of department-funded roles, so that our program can sustain that larger size. In addition, this grant has really increased our focus on interprofessional practice in integrated primary care, so that we are really focused on strengthening the integration of our training programs in psychology, psychiatry, and clinical social work with a specific focus on integrated primary care competencies. I'm going to discuss that in a little bit more detail on the next slide. Finally, I want to call your attention to our goal related to trainee diversity. We here at CHOP have had a really successful track record of recruiting trainees of diverse backgrounds, and we are continuing to refine our recruitment efforts so that we can increase the diversity of our training classes with the hopes of increasing workforce diversity in behavioral health more broadly. Okay, and so here you see our conceptualization of the domains of interprofessional competence that we consider to be especially important for the trainees in all 3 disciplines rotating in our integrated primary care service. We recognize that each behavioral health discipline has unique competencies that they must master during their training, so that's sort of the part of the Venn diagram that does not overlap, and our within-discipline supervisors address those training areas with each trainee over the course of their time with us in their training program. In addition, we consider these overlapping domains, the 6 that are on the rectangle there, that are not discipline-specific, but that are more integrated primary care-specific, and we address those in our experiential and didactic training on this track. My colleagues and I published a paper related to this work in in child and adolescent psychiatric clinics of North America, and there's the authors there for those of you who might be interested in more details about how we kind of outlined these 6 training competencies. Okay, and so then with all of that considered and our goals detailed as we just discussed, we started to think a little bit more about our evaluation plan and then how we'll proceed over the course of the project. And so I'd like to spend the rest of my time focused on the program evaluation plan and best practice suggestions. And at the time of our project development, our team developed specific aims and identified process and outcome measures for each aim. We felt that it was particularly important to include a multi-method evaluation plan, including objective and subjective measures, to ensure the collection of really rich data. Additionally, we're utilizing an iterative process of development that includes focus groups, surveys, and individual interviews with trainees and faculty for our aims related to curriculum development in particular, to ensure that we're really reflecting the feedback of all of our stakeholder groups in the department and in our training programs. So next, I'm going to kind of get into some more details about how we implement each of these components of our evaluation plan. Okay, so here you see our aims and process and outcome measures related to interprofessional training. Trainees in psychology are expected to get 300 hours of training in integrated primary care, which basically amounts to 1 day a week for the entire training year. And psychiatry and social work trainees should get 150 hours. They spend only 1 semester with us in this rotation. We ask all trainees to complete training logs, and then our outcome measure related to that is the number and percentage of trainees who meet that hours goal annually. And this is similar for our didactic trainings, the 15 hours that we expect. In terms of how we evaluate trainee competence, we have a multi-method evaluation process. So specifically, 4 times a year, or 2 times for the psychiatry and social work trainees, supervisors utilize a Likert type rating scale that we've developed here at CHOP over several years to evaluate trainees' performance relative to the end of internship expectations. So basically, at the time that our trainees leave here, we expect that they're ready for close to independent practice or getting ready for postdoctoral fellowship level training. In this manner, our ratings can then illustrate growth over the course of the year. So in other words, we don't expect trainees to achieve the highest ratings at the first evaluation period. We expect that their ratings are closer to 1s or 2s on all of our competencies, with movement toward a 4 or 5 by the time they graduate. In addition to that evaluation form, supervisors meet in the middle of the fall and the middle of the spring semesters to discuss in person trainee progress in each rotation, so that we get faculty supervising the integrated primary care rotation as well as the other rotations the trainees complete in person to try to identify common strengths and growth areas for each trainee. And then each faculty member has an individual in-person review meeting with the trainee about the specific rotation. And finally, the trainees all get a faculty advisor who meets with the trainee to support integration of their feedback and then refinement of their overall training goals if that's necessary. And then finally, to monitor trainee caseload over the course of the year, we have a dashboard that our faculty can use. And generally, as the program director, I'm the one who monitors that dashboard, and so I can keep track of trainee caseload and the number of patients that they're seeing, and then I use that evaluation feedback in a continuous process along with the training logs to ensure that the trainees are meeting their experiential training goals. So here you see kind of an illustration of that process, that on a monthly basis I monitor their clinical logs and their patient care dashboard, provide that feedback to the individual supervisors, and then they can kind of take a look and make sure they're on track for meeting their end-of-year expectations. And in most cases, our trainees have absolutely no problem meeting these goals. Our clinics are super busy, so they see plenty of patients. But sometimes patient show rates drop or there are other scheduling challenges, so we have to make adjustments to ensure that trainees are meeting their goals. And then as we think about our trainee recruitment, here's another example of how we use the RCQI process. And our goal at the start of the project was that at least 33% of trainees would represent racial or ethnic minority groups. And although we've achieved that goal, we would be really excited to be able to surpass it over the course of the year. In addition, this goal is specific to trainees on our integrated primary care track, although our training program leadership more broadly in the internship program is really motivated to increase trainee diversity just beyond our track. So we're in the process right now of engaging an external consultant to refine our plan for trainee recruitment as we're heading into the next recruitment season this fall. And finally, I want to discuss an example of iterative program development that's specifically related to curriculum revision. So we have multiple didactic seminars, and one of them is known as Interprofessional Seminar in Community Practice. We invite trainees in all 3 disciplines to the meetings, which occur 6 times per training year. The seminar usually follows a journal club format, wherein one of the trainees selects a journal article related to service delivery with underserved populations, presents that paper really briefly, and then leads a discussion among all of the trainees. And over the course of the 2018-2019 training year that we just finished in this past June, we saw trainee attendance and engagement in that seminar really decline, and our faculty we were concerned this is a really important seminar for us, and so we figured we had to really look at this carefully and think about how we were going to refine it for this coming training year. So our plan for an improvement included trainee feedback. We did interviews and a survey. Several of our program faculty conducted observations of the last couple of seminars in the training year, and then our training faculty leadership faculty discussed the seminar format, and that training leadership discussion included leadership from all 3 disciplines. And so then for this current training year, which actually just began last week, we now have a plan to refine the seminar, which is going to begin tomorrow with our orientation meeting with our new trainees. And we plan to pair the trainees across disciplines and ask them to work together to lead their assigned seminar sessions. So the trainees this year, we hope, will actually have a lot more flexibility to decide on the format, so it's not necessarily just going to be journal club anymore, and that, again, was in direct response to trainee feedback. In this way, we're hoping to give trainees more independence to be creative in their teaching and to encourage interprofessional work among the trainees. During this coming year, we're going to continue the evaluation process, including faculty observation and trainee feedback, to continue to refine this seminar if necessary. Okay, so basically I just want to wrap it up to make sure I give Dr. Phoenix her time, but it's important from our perspective, what we've learned is that we really feel that it is important to include a multi-method, multi-informant evaluation plan that includes all key stakeholders. So we have faculty leaders, all training faculty across disciplines, and our trainees involved in providing us with data as we go through the process. We also feel that it's incredibly important to keep the trainees involved in the program evaluation process as much as possible. So the RCQI process I discussed and some of the quality improvement projects that we've done have been either led by trainees or including trainees as team members. And in many cases, we get trainees who have very strong research interests, and they're highly motivated to help with this process and think about ways we can work on refinement. And then our trainees are involved, again, in doing focus groups and interviews. And one of the other things we found very helpful is that we are benefiting from having a very well-developed training program broadly outside the context of this grant. And relying on that existing infrastructure and resources, it has been tremendously helpful to us as we've developed and tried to implement our program evaluation plan. So that's all that I have to share right now. I can turn it over to Dr. Phoenix.
Well, thank you so much to Dr. Matone for speaking with us today about her program evaluation experiences. And we're going to hand the floor over to Dr. Phoenix now. As we previously talked about, Dr. Phoenix is with UCSF School of Nursing. So Dr. Phoenix, over to you.
So anyway, I'd like to just tell you a little bit about our project to enhance California's psychiatric mental health nurse practitioner workforce. So the overall purposes of this grant are to expand clinical residency placements in rural and primary care settings, because most of our clinical residency sites have been in specialty mental health settings up to this point. And to strengthen preparation of our graduates to work in interprofessional teams in integrated primary care and behavioral health. And in addition to grant purposes that were specific to the RFP, a major focus of this grant is to reduce the significant amount of financial stress experienced living by our students living in the very expensive Bay Area. So our specific grant objectives were to administer 18 stipends per year to students who are working with the key population specified in the RFP. And to do this, we are increasing our admissions to 34 per year. We were running about 28 to 30 before. And also recruit a larger proportion of our cohort from outside the Bay Area. And then increasing our number of residency placements in either integrated care or rural sites by one for each year of the grant. And then our third objective has been to collaborate with the pediatric primary care program in our university to do some joint coursework as well as a psychiatric consultation warm line in some school-based primary care settings where the pediatric primary care nurse practitioner program has residency sites. So there were 4 areas that we wanted to examine when evaluating our project success. And we started by looking at what data are already being collected by our institution and how we could access them. So the 4 areas we're looking at are students, placement sites, graduate outcomes, and then our project-specific objectives. So looking at the kind of student component of it, all these data are readily available through existing school and campus data systems. So the application system, the school publishes a yearly student census, and then eValue is a system that's used for tracking and evaluating students' clinical experiences. So not only are the evaluations of student performance in there, also the students' evaluation of the clinical placement sites are collected in eValue. And then again, for the clinical placement sites, all this placement data is in eValue. And unfortunately, it's somewhat cumbersome to retrieve. The system has a lot of functionality, which makes it sometimes a little bit difficult to find the actual functions you want to use. So we often, for a kind of quick and dirty evaluation, refer to the student placement worksheet that's maintained by program faculty as they're finalizing placements. For our graduate outcomes, we rely primarily on our own student survey that we use a Qualtrics survey for, that we send out to our graduates shortly after graduation because that fits the HRSA time frame. And we were hoping that we would be able to get more data from the School of Nursing graduate survey. But these surveys have a low response rate, and they also don't ask for some of the data that's required by HRSA. So we found that doing our own survey has been more productive in terms of getting this information. In terms of the project-specific activities, these are some kind of specific activities and some of the indicators that we use. So one of our goals was to develop a placement database with better functionality than what we currently use, which is basically Excel spreadsheets. Because of some changes that have been going on the school level, we have not been able to make these improvements yet because we're trying to coordinate with school activities. But what we really want to look at is, once we sort of refine the system, does this basically lead to less time and less headaches for the faculty and staff who are involved in the placement process? And then in terms of our joint coursework with the pediatric nurse practitioner program, we're primarily looking at course evaluations from students and what they get out of this. And then in the sort of the clinical training and clinical collaboration via the warm line, we want to look at the number of trainings that are provided to primary care providers and trainees, their satisfaction, and how well the warm line is working. This is another objective where we've had some delays because of key people who are involved leaving the university, but we're hoping to get it up and going in this coming year. So key points, use existing institutional data systems as much as possible to inform quality improvement processes, But when the institutional systems are too slow, too cumbersome, or don't provide the data that you need, look to develop your own data collection tools, because sometimes it's just more of a hassle to use these big data systems than it's really worth. So that's pretty much what I have to say. I'm hoping for questions, but I'll have to get them on the chat feature because I can't hear you all, unfortunately.
Wonderful. Well, thank you so much to both you, Dr. Phoenix, and also Dr. Matone, for taking the time to talk with us today about your program evaluation experiences. We've been interviewing different BWET grantees here at the BHWRC for the last year to ask them about their program evaluation experiences as well as student training. And your experiences, Dr. Matone and Dr. Phoenix, will really help other grantees who are just getting started with program evaluation and also those who are trying to adopt some new strategies. So we're going to take the remaining few minutes to open up the floor for any questions that some of the attendees may have. So feel free to enter those questions through the chat feature.
We have a question here in our chat. We have someone wondering, and I will chat this along to Dr. Phoenix. They're wondering if anyone can, either of you, conduct evaluations that benefit the host organizations. I do know from some of our research that we've done here at the BHWRC, there are BWET grantees that are actually the host organizations themselves that are receiving BWET funding. But I guess that question to you, Dr. Matone, do you do any evaluations that do measure benefit to your host organizations?
So that's a good question. I mean, I think that our focus, again, our training grant is awarded directly to CHOP, and our training program exists within our institution. So we kind of are the host organization. The trainees rotate in our own networks. So all of the evaluation that we do related to improvement in our integrated primary care service informs the Healthy Minds, Healthy Kids program more broadly, and not just the training program. In terms of how we're serving families, we have a component of family engagement and service delivery. I focus a lot on what we do to support and evaluate training and trainee involvement, but we also have an evaluation component that looks at family involvement in the service and that family access to behavioral health care, and that is really informing our pediatric primary care practices broadly. So I think that's maybe that gets at what the question is asking.
Okay, so this question is, do you conduct data to evaluate benefit to your host organizations? So I guess the data that we collect that would be relevant to this really is mostly collected during site visits, as well as student evaluations of student performance by the site. Other than that, we don't really have a formal way of doing it. But I think just the fact that organizations are willing to keep taking our students year after year indicates that they benefit from having our students in their organization, because if they're not getting benefit, they don't continue to take student trainees.
Thank you, Dr. Phoenix.
Well, that is all the time we have today for questions. So if there are any remaining concerns, questions, comments that you have about today's webinar and anything covered, feel free to contact Jesse or I through the BHWRC website. And like we said, we'll make the recording of this webinar available next week. And thank you so much to Dr. Matone and Dr. Phoenix for taking the time today to share all of this useful information with us. We really appreciate it. So without further ado, thank you again and enjoy the rest of your day.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.